Good morning, everyone. Good morning to the chairman. First of all, I would like to thank the opportunity to be here in this ICS 2014 Rio and get the chance to show our work. And I also want to thank the ICS Travel Award Committee because I was one of the winners of this award, so thank you very much. Here we have a study that we developed at Federal University of São Paulo. It's entitled Urodynamics Before Benign Prostatic Obstruction Surgery. Who won't make the cut? So we know that pressure flow studies, they define bladder outlet obstruction. And we also know that in the absence of obstruction, it could lead to poor results after surgery. So after all, who are the patients that would benefit from urodynamics before benign prostatic obstruction surgery? In materials and methods, we had 311 consecutive non-neurogenic patients, all of them with clinical indications of surgery for low urinary tract symptoms, BPO. They had either therapy failure or urinary retention. Those patients, they all did the urodynamics and they were divided according to the Schaefer nomogram into 4 different groups. The first group was the patients with pure obstruction. The second group was the patients with normal results. The third group was the patients with detrusor underactivity or a contractile detrusor. And the fourth group was the patient with obstruction and some degree of underactivity. Here we have the distribution of groups. We have that almost 60% of the patients were in the first group, the obstructive one. Only 3% of the patients with the normal results after the urodynamics, almost 10% of the patients with underactivity or a contractile detrusor, and 1/3 of the patients with obstruction and underactivity. Here are some urodynamic findings in our study. We found that almost 90% of the patients had a bladder outlet obstruction. Half of the patients, detrusor overactivity, and almost 40% of the patients, detrusor underactivity. Analyzing our data, we found some independent factors, and the first one was the Qmax. And the Qmax was an independent factor associated with normal pressure flow study with significant result. Here we can see that in the normal group, 100% of the patients had a Qmax higher than 10 ml per second. Very different from the other groups, that the best one, the obstructive one, only 1/3 of the group had a Qmax higher than 10 ml per second. Another independent factor was the post-void residual. So the PVR was higher in the patients with obstruction and underactivity, and the PVR was lower in the patients in the normal group. And it was an independent factor associated with the presence of obstruction and underactivity. Here we see that patients in the group with underactivity and a contractile detrusor plus patients with obstruction and underactivity, almost 45% of the patients had a PVR higher than 150 ml. Very different from the obstructive group, that less than 10% of this group had a post-void residual higher than 150 ml. And the last independent factor was according to the prostate volume. It was higher in the patients with obstruction, and it was an independent factor associated with pure obstruction. Here we have that 90% of the patients in the obstructive group had a prostate volume larger than 40 grams, very different from the patients in the underactivity group, that only 50% of the patients had a prostate volume larger than 40 grams. Here with another result, we can see that as the higher the obstruction, lower the underactivity. So patients in the Schaefer's grade 2, 3, and 4 with underactivity are the patients that require individual assessment before surgery, because they might not get as well as we want them to be after surgery. So they should be individual assessed before surgery. In conclusion, we have that half of the patients benefit from urodynamics assessments before surgery, because a little bit more than half, 50% of the patients had a pure obstructive result in the urodynamics. 12% of the cases, the indications of surgery was not supported by the urodynamic diagnosis, because either they had normal results or they had only underactivity or a contractile detrusor without obstruction. And 1/3 of the patients required individual assessment. As I told before, those patients had obstruction and concomitant presence of underactivity. So those patients had to be informed about the prognosis of the surgery. So regarding all this, we believe that urodynamic studies, they are an important tool before BPO surgery. Thank you.
Hello, congratulations for the paper. I have one question. What criteria did you use to classify the patients as detrusor underactivity?
We basically use the Schaefer nomogram. According to the Schaefer nomogram, we consider patients with obstruction with a grade 2 or higher, and patients with underactivity according to the Schaefer nomogram.
Okay, I asked this question because I have some questions in this subject. Recently, I saw a paper that the outcomes of the surgery was they separate different groups of different grades of detrusor underactivity. In my opinion, we need more papers in this subject because it's different. If you use bladder contractile index, you have under 100. It's different if the patient is 20 in the bladder contractile index or he's 80. And everybody is classified as underactive bladder. Okay. So it's one thing, one subject to the audience and for us. We need to stratify these patients, in my opinion, because you have different results in the post-surgery. You have hypocontractility patients, underactive bladders, that go better, but it's not the worst case. Thank you.
Okay, perfect.
Just got my question. I mean, how do you define underactivity? Because some of the guys, they believe that you have to monitor the pelvic floor, and more than that, the urethral sphincter with EMG to state underactivity bladder.
How did we classify as underactivity?
Yes. How do you state underactivity?
So in our institution, we don't have the EMG, sorry. And we only used the Schaefer classification to determine if the patient had some underactivity or not. We used only the Schaefer nomogram.
Because this can be a flaw, because the underactivity area and the nomogram Schaefer can be only non-obstructive and not underactivity.
I'm sorry. The Schaefer nomogram is the golden standard on the basis of good analysis of detrusor working function. And there's no standard that can improve what you did. I confirm your results. There's only pressure flow, and there's a relation between pressure and flow, between force and velocity. And you need a few formulas to make that relation, but it's elegantly saluted in Schaefer's nomogram. And EMG, I'm sorry for you, plays no role in detrusor or underactivity. And yes, Daniel, sorry, but linear PER is the best applicable golden standard, and bladder outlet or bladder working ICS bladder working factor is the derivative of that nomogram. So you did the best thing you could, the best knowledge. The only thing that we miss on the detrusor underactivity is that we measure the maximum contraction and not are well able to measure the endurance of contraction. And there's a problem with ineffective emptying. But as far as the science is now, and the predominance of the evidence is that maximum contraction, as plotted on the Schaefer nomogram, is the golden standard, undisputed.
Peter said, but we have to consider at least two issues. First of all, if you talk to a physiologist, what they call contractility has nothing to do with what we call contractility. because in physiology, contractility is the ability to generate force in an isometric contraction. When we say contractility in a human bladder, we mean something that is totally different. The other problem with urodynamics is that we assume that using the Schaefer nomogram, a low amount of work means detrusor hypercontractility. This is a nonsense, because we have lots of patients who are unable to activate their detrusor. The detrusor is absolutely fine, but because of inhibition, for example, from the urethral catheter, the detrusor is not activated. And we report, detrusor underactivity, but it's not there. I have shown lots of my residents that by taking the urethral catheter out and putting a suprapubic tube, the patient who was unable to void suddenly became able to void. So we got to be careful, because we call everything detrusor hypercontractility, but we have hypercontractility and lack of activation. We can call it underactivity. There's no agreement about that, but at least we should acknowledge that some detrusors simply are not activated properly, but they still function well in the proper circumstances.
Yes, that's my point. I mean, if you want to really state a contractile bladder, you have to monitor the detrusor, and also
I don't think
with the
we are
pressure.
discussing acontractile bladders.
Acontractile
And
bladder.
some are just unable to void during urodynamics. And
Yes.
some are just shy voiders and will never be able to perform normally in your office. But
Yes, that's true.
the older guys that show up for this study, if you allow them to void them in a preferred position and not overfill the bladder, and ask them whether they have a serious need to go, only about 10 or 15%, depending on how you do your urodynamics, is unable to void. And all the others, you can just ask your patient, was this the way you void? Almost as usual, and 90% will say, yes, this is representative for me. And yes, some are unable to void, and some are unable to make a voiding contraction. Again, EMG is unhelpful in there. I'm sorry.
I agree with all of you, but I think I agree with the Rosier. The Schaefer nomogram and BCI are the gold standards now for classifying underactivity. I think we need better tools to do that. But if we, and I think you're right also if you say that in a urodynamics a patient cannot void, sometimes because of the catheter or other factors. But if we operate those patients that have a degree of underactivity, we can see on the post-op that some of them, they keep on the contractility curve. So the contractility that they had before the surgery, they keep after the surgery. So that's something to say that the nomogram is actually right.
Yeah, but I mean, I wouldn't like everybody to go out of this room with the idea that EMG is useless when looking at bladder function, because every one of us who's doing pediatric urology knows that in little girls, this is what we do.
Mm-hmm.
We do, yeah, but I mean, the pelvic floor plays a role. Said, as you put it, Peter, I think was a little bit too strong. I can agree that in men, it doesn't.
In contraction and contractility, you are very right in that, and we should sort out that terminology. But for the old man, there's nothing to do with pelvic floor.
Last question.
Yes, I have two questions, sorry. What do you think about to have a ambulatory long-term urodynamics in those patients where the standard urodynamic is not clear, or you think it's underactivity? What else? What do you think, first question, about long-term urodynamics? And second question, I think in all these discussions, it should be included also the quality of prostate ablation. there is no model including the quality and the learning curve of the surgeon. I think this is a very important point, that you assume you have the best ablation, but in many studies you are not sure that this is true. Thank you. First question, long-term urodynamic. Second question, quality of ablation.
Did you ever consider doing ambulatory urodynamics in these patients?
Afterwards, after following them?
Yes.
Yes, we're trying to do further studies about this subject, and that's I think we're considering to follow those patients, and a possible thing to do is to repeat the urodynamics in the long term.
And the other question is about the quality of the surgery.
Quality of surgery?
Yes, I mean, I know everybody believes that he is a great surgeon, but some of the procedures are poorly done. You know, so what the colleague was suggesting is to look into the quality of the surgery, because this may be important to evaluate your results.
How can you measure the quality of surgery? Right, because you can operate, like if you are an experienced surgeon, you operate well, you have a large number of surgeries, and your patient doesn't do well, that means you operate, you did the surgery.
Well, I can give you an answer. When we completed the Goliath study, laser green light versus TRP, our average mean Qmax value for TRP was 23 ml per second. There are trials out there with a mean Qmax value of 16, and people tried to tell me that 16 ml per second maximum flow rate is normal after TRP. That was just bad surgery. You know, so I agree with your point. It's not easy, but you have to consider it, because when we look at outcome, you have to tell me how you judge it.
No, sure, but if you have a patient with underactivity, for example, he won't get a high Qmax after surgery, right? If you have a pure obstructed patient, probably he will get to 20 plus Qmax. But if you have a patient with some degree of obstruction and a degree of underactivity, probably he won't get to 20 plus Qmax, because he doesn't have the detrusor to get there.
Interesting point, but in the interest of time, I think we have to close and continue the discussion at lunch.